Hello, I'm Joan Justice from HealthWorks Collective, and I have with me today Dr. Ruchi Das from India. Dr. Das is an expert on mHealth. Dr. Das, tell us a little about your background and give us, if you would, your definition of mobile health.
Hi Joan, thanks for having me, and I'm actually appreciating all of your efforts these days, reading Healthcare Collective every day, so good effort, keep it up. So my name is Dr. Ruchi Das. I'm a physician by education and lost that to public health a long time back. When I was doing deployments with some of the basic NGOs in India, I realized when you have to reach out to millions of people, you need to harness technology. So hence was the interest in healthcare, IT, e-health, and mHealth. So what I'm known for is mHealth, but what I'm trained is in healthcare IT. I'm also the CEO of HealthWorks Consulting Group, which is the only niche consulting group based out of Asia. We help industries, people, and providers adopt to low-cost solutions, bring them to scale, and get them working in Asia-Pacific markets. So that's it in all what we do. My mobile health definition is pretty simple. Mobile health is not about healthcare on mobile phones, and I think that's the misconception people feel about. It's healthcare which is mobile, which is wireless, which is anytime, anywhere, wherever you need it, however you need it, by whatever you have at home, be it your mobile phone, be it your set-top box, your television, radio, iPod, think of it and you can get it anywhere. So that's the kind of world of healthcare which we are talking about, and that's my definition of mobile health.
Thank you for that. In your post, you mentioned that empowering rural India is one of your primary concerns, and you mentioned the need for broadband penetration and financial commitment. Currently, what percentage of the Indian population has access to standard health care, and then what percentage of the population has access to some form of telehealth?
Empowering rural patients, empowering rural India. You must have heard of this phrase like a million times, but what does it actually mean? In India, 70% of population lives in rural areas, where 1/3 of the healthcare facilities are. So we are talking about a steep doctor-to-patient ratio, which is 1:1,000, which goes even steeper when you move to villages. So it is very, very imperative to empower these people with the right kind of information, with basic healthcare access, and with empowerment so that they can afford healthcare. Today, at this point in time, I think we need more than 700,000 beds per 1 million population, and we have not even reached half of it. So why we are talking telemedicine today is because we know that if we keep building hospitals, if we keep bringing in more doctors, that's never going to gape the divide. What we have to do is create hub-and-spoke model so that wherever you are based, you can walk into a telecenter facility that is connected to a secondary healthcare facility and in turn to a tertiary healthcare center, and you can get your advice sitting at your home without thinking about how to reach there, how to get access to this benefit. Talking about statistics, as you said, how much of it is covered already? We have 20,000 primary healthcare centers in India, and out of them, 300 are already connected through a telecommunication link to 43 super specialty hospitals. That is on the government side. On the private side, Apollo Hospitals Group, Fortis Group, Amrit Group, and Narayan Hidale, all of these hospitals are building in their independent nodes to provide telemedicine to the far-flung areas. And I can say that while 25 to 30% of Indian population already have access to basic standard healthcare, the remaining 70% of it will soon get access to healthcare through the telemedicine effort that we are bringing into the country.
Thank you. Electronic health records are now being adopted by the United States hospitals, but it is a challenge. We're having problems with hospitals talking to each other. Each system seems to have its own platform and they're not compatible with each other. I can imagine that it's the same in India. Can you comment on this?
So electronic medical records are seen in a different light in India. When hospitals share it with other hospitals, that is considered to be loss of business for them, so they don't do it. Back there in 2006, there were no incentive models, there were no mature reimbursement models, so hospitals call it quits. They are not willing to do it, they are still not willing to do it. And the patients started themselves maintaining some kind of health records on different websites so that they can share it amongst establishments. But doctors are not relying on those records because there can be typo errors, there can be other problems. And for example, your blood group, it says B positive in your health records, but when the transfusion happens, something goes wrong because the doctor is relying on those records, it can be devastating. So in India, it's different because people really don't see a use case for the adoption of EMR. However, with things like Aadhaar, which is the unique identification concept coming in India, I think it will have a lot to do with EMR adoption, with interoperability, with doing something which will be like a one-stop shop for all these people to connect seamlessly. So I think while this is happening on one side, on the other side, what government need to do is put in legislations in place so as to how UI looks like, what the middleware should be. Interfaces need to be understood nicely amongst all system players so that there is no restrictions to access or what we call as implementation. So that's the problem. In US, however, there's a lot of support that comes from the government bit of it, which doesn't come in India. So Obama recently said that anybody who wants to use an iPhone or an iPad will be given more than $44,000 if they comply to what you call as meaningful use. Yeah. So it does not exist in India. But yes, there are problems related to standardization. They're the same as they are in the West.
Yes. Okay, thanks. That's what I imagined. In your post, you mention a citizen health information system. This seems like a major undertaking. And what is the first step to be taken here? And when will this project start?
CHIS is a fantastic and a beautiful concept. I think with CHIS coming in, it's like a flora and plethora of opportunities that will actually come into place. CHIS will not only monitor the concentration of disease in a particular area, but will also keep on updating your electronic medical record based on your biometrics, the kind of services you use, the kind of supplies that are provided to you by government, and so on and so forth. And it all happen in just one place. What you call as citizen health information systems will also provide seamless connectivity amongst the primary healthcare centers, secondary healthcare centers, and tertiary healthcare centers, so there can be healthcare information exchange, and you can get best consultation at the right point in time whenever you need it. So this has already been started. And at one point in time, what we call as Swabhiman, what we call as Aadhaar, what we call as CHIS, they all will be talking to each other to bring the maximum impact in the society that they can. So this has been already started. Aadhaar, people are still, busy in completing the existing mandate, but the next step is definitely healthcare. So CHIS, Aadhaar will be interconnected with what we call as RSBY, which is Rashtriya Seva Bima Yojana, which is a health insurance policy for rural India. All of this will be connected, and I think 120 million people are already there on the Unique ID project, which is going to go to 600 million by the next 5 years. So it's a world of opportunities in India.
Okay, this Unique ID project, is this the project I've heard about where each individual is going to be supplied with an identity card?
Correct. So this is the project where everyone who is born in India, is a citizen of India, even if an infant, will be provided with a unique identification number, that is a 12-digit number, on which your biometrics will be there. It is on a cloud-based technology, so it's kind of plug and play. So there will be a whole lot of opportunities to become a part of Aadhaar once it's there. It eliminates a lot of things. It eliminates human error, duplication of records and identities, and makes things pretty easier for you to build upon.
Wonderful, wonderful. And what percentage of the population, has it started yet, this project? And how far along is it? What percentage of the population?
100 million people, I would say, have already opted for Aadhaar cards. It's actually going very, very strong. And the idea is that in the next 2 to 3 years, it will cross 600 million mark.
Ooh, wonderful. And you also mentioned the disease surveillance project. And how does this work?
So, correct. So, in India, healthcare is a state affair. So, every public health funding that we talk about, 80% of it comes from the state, and the rest of it, 15 to 20%, comes from the national health programs. So disease surveillance is an annual concept for each and every state. They submit a report saying these are the 5 major diseases that are leading to morbidity and mortality in the area. And based on that, the funding is provided and the programs are being made, that is government campaigns, so that they can reach out to the remotest of areas and can provide this information to people. So disease surveillance for now is being done on a very manual manner, where there's a representative who goes with survey questions door to door and collects this information. But with CHIS and Aadhaar, that's a unique identification project coming in, this will all become automated. You can actually do it on a mobile phone by yourself sitting at your home, or a healthcare worker can do it for you on a PDA, which is much easier to carry, a better user interface, and it's quick and convenient.
Wonderful. That sounds great. I've published several posts on the use of mobile devices in India for telehealth, and I'm sure there are numerous projects going on, but is there any overall strategy?
Very good question. So in India, there's World Bank that is active, Bill and Melinda India Foundation, then there are hospitals who are volunteering for mHealth. But all of it, it's like, it's happening episodic, it's point-based, and it's not a part of the concerted strategy method. So there is a strategy behind it, but for a use case. We are still lacking a cohesive strategy that has a meaningful reimbursement model, a business model that will keep all the stakeholders in the value chain incentivized and intact, which is lacking today. But with the 5-year plan coming in and the Department of IT working with Ministry of Healthcare, there will be a strategy coming in very soon, where we'll talk about standardization, we'll talk about legislation, and we'll talk about a cohesive strategy of how to get all of these people on board. One interesting example here is RSBY. It's the only most successful project in India that has gone in the health insurance bit of it for rural India, where there are players like NGOs, hospitals, SMEs, Government of India, public-private partnership. It's a very big example of this, and it has already reached millions of people. We are probably going to duplicate the same bit of it, but not for the payer side, this time for the provider side.
No, okay. Well, keep us informed on that. It sounds wonderful. As India goes forward in the adoption of mobile health for all of its citizens, what is your primary concern?
My primary concern is evidence, and though there are several things happening in India and it's happening in every nook and corner, there is no centralized database that would tell us of how and what is already being tried and tested and how not to do any expensive mistakes. So it is very imperative that we keep learning about what we tried, what failed, and what we are trying that succeeded, so that it becomes it comes in the grand scheme of things rather than being in a one corner or a point solution kind of a thing. That's one concern of mine. And second is research. So though we are doing a whole lot of stuff, there is little research which is being done about the overall strategy bit of it, the business models bit of it, and little research about. So as I said, India is a land of diversity. Which clicks in North India might not click in South India. So I keep saying this in all of my speaking assignments, that India is not one country. India is like 26 countries, because they're like 26 states independently managing healthcare of the nation, and their priorities are different, and what works there is different, and the customer behavior and the lifestyle and everything is so different that sometimes it becomes a problem to learn from some of these ideas and to implement this at any other stage. So I personally feel that is my primary concern. However, I'll tell you about my secondary concern also. There are limitations to technology, and sometimes people feel that technology can replace a doctor, which I really don't agree to. One of my mentors says this, and I would say that again, a fool with a tool is still a fool. So I think that it makes a lot of sense to empower doctors and patients with the right kind of information and tools, but you really can't replace a doctor from the value chain.
Exactly. I agree wholeheartedly. Well, thank you so much for all your input, Dr. Das, and I hope I have the pleasure of speaking with you again.
Thank you. You have a great day. Thanks for having me.